Good afternoon. My name is Ann Brazo. I'm the CEO and founder of MPN Advocacy and Education International, for those of you that do not know me. And we host many, many webinars throughout the year, up to 17 sometimes. And we're thrilled today to have Dr. Brandi Reeves with us from the University of North Carolina, my brother's alma mater, Tar Heel through and through. And Brandi will also be joining us in Asheville in August. And the subject matter today for PV patients is really fantastic. Blood cell count targets in PV, what are they and what do they mean? And so please welcome Dr. Brandi Reeves, and she is going to take us through this, and your questions are welcome.
Hi,
Thanks,
thank you
Brandi.
so much, Ann. Nice to virtually meet all of you today. Here are my disclosures, none of which is relevant to today's lecture. And I thought I'd first start with who am I? So I'm a physician scientist, and I focus my research on why blood clots a little too much in MPN. And I did my internal medicine residency training at the Mayo Clinic in Rochester, Minnesota. And then I did my hematology fellowship at the University of North Carolina in Chapel Hill, where I've stayed on. And now I lead the UNC MPN program here. And of course, as you all know, I couldn't do this all by myself. I have an absolutely fantastic team. So there's another doctor in my team, Hank Van Deventer. We have a nurse practitioner. We have our own clinical pharmacist dedicated to MPN, a nurse navigator, Jen Kelly, who's on and who's going to speak tomorrow. And then we have these amazing intake coordinators to help get new patients in. And so we actually established our clinic in 2019. And at the time I wrote this slide, we had over 400 MPN patients. We're now up over 500 MPN patients, and we're adding about 100 new patients every single year. So we're a pretty busy clinic, and we see a lot of MPN-related cases. So in today's talk, I'm going to divide it into two segments, and I promise it's going to be pretty short. So first is I want to go over the basics of polycythemia vera, or PV, to make sure we're all on the same page. And then I want to go over treatment goals of PV, in particular, not what treatments are best, but what are our cell count targets. So that would be hematocrit, our white blood cell count, or WBC, and our platelets. And are these really fixed targets, or are they moving targets? Are they different for different people, and are they different for different treatments? So first, the basics. So polycythemia vera is what's called a myeloproliferative neoplasm, or an MPN. And you all have probably heard this alphabet soup of PV and MPN, but really MPN comprise a group of neoplasms, which are technically chronic blood cancers. And there are three main types of MPN. The first is polycythemia vera, or PV, and that's really where you have too many of all your cells. So too many red cells, too many white blood cells, and too many platelets. And most of these patients are going to have a JAK2 mutation. Then there's essential thrombocythemia, or ET, where predominantly it's too many platelets. About half of these patients have a JAK2 mutation, but then the rest have other mutations, including calreticulin, or CalR, and then MPL mutations. And then there's something called primary myelofibrosis, or PMF, which has variable cell counts, but really has a lot of scarring in the bone marrow, and usually is quite symptomatic with big spleen. Has about the same breakdown in driver mutations as ET. Both PV and ET can progress to myelofibrosis, and all of these diseases can ultimately progress to acute myeloid leukemia. And so in thinking about what is an MPN, so an MPN is a disease of myeloproliferation. So we have our really early stem cells pictured here at the top, and those stem cells can break down and generate what we call myeloid cells, which are ultimately the red blood cells, the white blood cells, including the neutrophils, and then the platelets. And then we have the lymphoid cells over here. So myeloproliferation is going to be too many of these myeloid cells. So it's not a lymphoid problem, it's a myeloid problem. And this happens in the bone marrow, which is the factory where all of our blood cells are made. And so you're not born with this problem. It is something that's acquired over time. And it's acquired in a cell that gets signals from the body to make more blood cells. So the way that our body normally works, we like to keep all of our blood cell counts in a really tight range because too few cells cause problems and too many cells cause problems. And so the way that our body communicates with the bone marrow, the factory, to say, hey, I need more, or no, I've got enough, are these signals called cytokines. And so here, the blue little circle is a cytokine called erythropoietin that's made by the kidney. And erythropoietin, when it's made, circulates around. It finds its receptor in the bone marrow on a stem cell, and it activates that cell. And the activation pathway goes through a set of doors called JAK. When JAK gets activated, it sets apart a whole new series of events. And ultimately, it tells the brain of the cell, the nucleus, to make more cells. So there are other hormones that can do this. So for EPO or erythropoietin, it says to make more red blood cells. But there are also other signals like thrombopoietin or TPO that can signal to make more platelets, and then GCSF, which signals to make more white blood cells or neutrophils. Now, in the case of a JAK2 mutation, you no longer need the EPO to have activated JAK signaling. So the JAK is now always on, and you don't need the signal from your body. So ultimately, those cells that are mutated are constantly making the signal to make more cells. And that can occur, and it could be just red blood cells, but usually these mutations happen in a very early stem cell that affects the production of red blood cells, of white blood cells, and of platelets. So then why do we care about polycythemia vera? So first off, while we consider this to be somewhat rare, there are plenty of patients living with polycythemia vera, so almost 200,000 estimated in the United States. And we think that this is probably underestimated. And as people are getting blood cell counts more frequently, we're finding more and more cases. We also care because this significantly impacts the quality of life. So in the landmark study of polycythemia vera, 66% of individuals with PV said that this really impacted their overall quality of life. And then we also care because it reduces overall survival. So we're going to look at that just a little bit next. So in terms of symptoms, patients with PV, so a few of them may have no symptoms, but most of the time there are some symptoms, and they can be mild, as seen here in the light blue, or they can be moderate in about a third of the cases, with fatigue being the biggest complaint, or they can actually even be severe, really significantly impacting quality of life and sometimes even vitality in terms of being able to work. We also care because there are thrombotic events, so blood clots. Those can include heart attacks, they can be strokes, they can be blood clots in the legs, in the lungs, blood clots in the liver, something called Budd-Chiari syndrome, and blood clots in the brain that aren't really strokes, but they're affecting the veins along the brain. And that occurs in about 1 in 5 patients, or 20% of polycythemia vera patients. So that's pretty common. We also care because this polycythemia vera can progress to myelofibrosis, and that at 20 years, about 1 in 5 or 20% will develop myelofibrosis. And the dreaded progression to acute myeloid leukemia occurs in about 1 in 8 to 1 in 10 at 20 years. So that gives us a rate of progression to myelofibrosis of roughly 1% per year, and to acute myeloid leukemia of approximately 0.5% per year. So if you imagine that you're diagnosed at 80 and you have a 20, or excuse me, at 60, and you have a 20-year overall survival, then you start talking about real risk of progression to these things. In terms of survival, if we look at the blue line as expected survival in the general population, versus the red line, which is the expected survival in polycythemia vera, you'll see that polycythemia vera is expected to shorten the survival by roughly 5 to 10 years. So the average overall survival is 13.7 years. Now, I will say with a very big caveat that most patients with polycythemia vera are diagnosed at age 60 or older. Those who are diagnosed at much younger ages, such as 40-year-olds, have a significantly longer overall survival than those diagnosed later. And then some things that you may not have heard about, but that are certainly on all of our radars in terms of what else happens to individuals with MPN. Chronic kidney disease is something that's really starting to become apparent. So in a study from Germany where they looked at over 4,000 MPN patients, 22%, again, about 1 in 5, had pretty significant chronic kidney disease, as compared to only 7% in the general United States population. So that's a big increase in chronic kidney disease for no apparent reason. There's also a really big increase in the rates of osteoarthritis in MPN patients versus the US population over the age of 60, where it's measured at 10 to 15%. And this wasn't just based on symptoms of bone pain. This study actually looked at radiographs looking for actual radiographic evidence of osteoarthritis. Now, currently we don't know how to manage either of these things, but it's becoming clear over time that MPN really impacts more than just your risk for blood clots and for symptoms, that it can have impact on other organs, including bones and kidneys. All right, so then if we think about polycythemia vera treatment with these in mind, so what are our treatment goals? So in terms of symptoms, we definitely want to address those, right? And many of our therapies can address most of the symptoms. Fatigue, I would say, is one of the hardest symptoms to address, along with concentration problems. We certainly want to address thrombosis because that is the most common cause of mortality in polycythemia vera. So, and if we address the thrombosis issue, then that should lead to increased overall survival. So we like all of those things. We also hear from patients that you worry a lot about progression to myelofibrosis and acute myeloid leukemia. But so far, that treatment goal is a little elusive at this time and is not something that we're primarily focusing on. But it's a topic of a lot of research that's currently ongoing. So in the current management guidelines, so I took this from the National Comprehensive Cancer Network, which is what most of us in the US use as kind of our general guide to how do we treat different cancers. So these guidelines suggest that we break down polycythemia vera patients into 2 treatment groups, and this is also consistent with what most experts currently say. So the first group is considered low risk, and that's low risk of blood clots. So these patients are under the age of 60, and they have no history of prior blood clots. And if you meet both of those criteria, then your risk of blood clots per year is roughly 3%. So it's not 0%, but it's much lower than high risk, so it gets put in this bucket. And if you look at what they suggest for treatment, so manage cardiovascular risk factors, so that's going to be things like addressing smoking, making sure your cholesterol looks okay, diabetes is well controlled, blood pressure is well controlled, starting a low dose aspirin, which we also call a baby aspirin, every day, and then phlebotomy to maintain hematocrit less than 45%. So here's the first time you're going to see a cell count target. So hematocrit less than 45% makes the guidelines. You see here that we're not talking about the white blood cell count or the platelet count, except when we start getting over to the are there other things going on, where they start to mention, do you have progressive thrombocytosis? And when you look at the reference, they're talking about platelets that are greater than 1,500 or 1.5 million, depending on whether you're British or American. And then leukocytosis is a fancy word for elevated white blood cell count. And generally they're talking about white blood cell count that's 50% elevated from normal. So if normal, upper limit of normal is 10, they're talking about 15 here. But again, they're not naming targets for what we should be normalizing those, or what should we do? When we look at high risk management, so that's either you age into being high risk by being 60 or older, or you get a blood clot and you're in the high risk club, that risk of blood clots is now significantly higher. And now we're talking 5 to 9% per year. When we look at the management, you see the exact same thing as we did for low risk. So we want to manage the cardiovascular risk factors, begin baby aspirin, phlebotomy to maintain the hematocrit less than 45%. And again, it's the same hematocrit goal regardless of high risk and low risk. But then they also suggest cytoreductive therapy, which is something that you might have heard of. So instead of just doing phlebotomy to get rid of the blood cells, they recommend that you be on something that helps suppress the production of those blood cells. And so that could be hydroxyurea or an interferon, or maybe even the JAK inhibitor called ruxolitinib. And again, there's no mention of platelet count targets or white blood cell count targets here until you're over here into inadequate responses, where they're talking about progressive elevations of platelet counts and progressive elevations of white blood cell counts. So we're really talking about controlling the hematocrit here. So let's talk a little bit then about what is our hematocrit goal? What is hematocrit and why do we care? Why is this 45% magic number in our guidelines? And so first, what is hematocrit? So if we take a sample of your blood and we put it in a tube and we spin it down to separate the cells, we get a layer on the bottom of red blood cells, and then there'll be a tiny little layer above it that are white blood cells and platelets. And then there's this clear stuff above it that's plasma. So the plasma contains, it's the liquid portion of blood that contains our antibodies and our clotting factors. And so our normal hematocrit, let's say here, is 45%. In polycythemia vera, the hematocrit's increase. So you'll have more red blood cells in the same volume. So effectively, you have less plasma around. And when that happens, as you might imagine, the fluid is thicker. So that's what we call increased serum viscosity. So much like motor oil, if you are familiar with cars, you always want to change your motor oil, right, to keep the car running smoothly, because the car engine has to work so much harder if that oil is old and thick, and you have to pump against old, thick oil. So the same thing happens in your body, which you can see here. So if you look at how thick or viscous blood is based on the hematocrit, so that's the percentage of red blood cells in the volume, you can see that as the hematocrit goes up, the viscosity really goes up. And so this is the viscosity of normal blood. And so if your hematocrit really starts going above 45 and 50, sometimes even 60 when people are diagnosed, you can see that the blood gets really thick and might well predispose to blood clots because it's not moving super quickly through the blood vessels. So one of the first studies that we had that really helped identify our hematocrit targets in polycythemia vera was a study called CytoPV, which was published in 2013 in the New England Journal of Medicine. And in this study, they randomized polycythemia vera patients to either maintaining a low hematocrit, which was less than 45%, or a high hematocrit, which was 45 to 50%. So there'd been a long-standing argument about what was better. 50% is close to normal, really can't be that much difference than 45%, but because of this viscosity curve, there'd been a big scientific argument that in fact lower hematocrits were better. So they set up the study that way. Now, in this study, patients could be treated with therapeutic phlebotomy or with hydroxyurea or with interferon. It was the physician's choice as to how they got the hematocrit. So everybody's kind of mixed across the board. So what you can see is that the low hematocrit group had significantly fewer events, and in this case, it's blood clots, than those with a high hematocrit group. And they actually stopped the study early because there was such a big difference between these two groups. So in fact, they saw 75% reduction in the number of blood clots if you maintained your hematocrit less than 45%. And so that has become our benchmark hematocrit for polycythemia vera since 2013. Very recently, Aaron Gerds and colleagues published an analysis from the REVEAL study, which was an observational study. So this was not a treatment study, but they enrolled 2,500 polycythemia vera patients, and they followed them over several years. And they wanted to know what happened in terms of blood clots and other outcomes based on blood cell counts. So data about these patients were entered over several years, and then they looked to see whether hematocrit of less than 45% or greater than 45% actually matched the results that they saw in the CytoPV study. And lo and behold, it does. So if you look here, anything to the right of this 1.0 means that the lower hematocrit was better. Anything to the left would mean that the higher hematocrit was better. And if it crosses the middle, there was no difference. So here you can see that maintaining the hematocrit less than 45% was in fact associated with almost a twofold lower risk of blood clots in this observational study. So again, this is validating the less than 45% target. But many of you here may be like, wait a minute, I've been told that I need to keep my hematocrit less than 42%, or I feel better when my hematocrit is 40%. And I will say that I don't think that this is a one-size-fits-all hematocrit target. It's definitely the baseline target, but there are certain populations, including, I believe, women, who should keep the hematocrit lower. So for women, it's suggested that you maintain a hematocrit of less than 42% because men have 10 times higher testosterone levels than women, so that boosts their red blood cell production. So when you look at all body weights of men compared to women, women have fewer red blood cells per volume. So in fact, at all body weights, women have 600 milliliters fewer red blood cells, which is about 1 bag of blood or 1 unit of blood, which is about 3% hematocrit points. So that's where this 42% comes in. They weren't able to study it in the CytoPV study because they had to close the trial early, and there's not been a study of men versus women with hematocrits, but that's where it comes from. And that's why many of us will recommend for women hematocrits less than 42%. Usually what I say is I recommend less than 42% unless you can't tolerate. And then I'll say, well, we need to get it at least 45% or less. And again, as I mentioned, some individuals actually feel better when their hematocrits are even lower. And so we have a few patients who prefer hematocrits of 40, sometimes even 38. And they notice when their hematocrit gets above that, they really start having more PV-associated symptoms. So we definitely individualize this hematocrit goal. So then what about white blood cells? So we've been hearing a lot about those lately with all of the data that's been coming out. And so I'm not sure if this is going to, oh, I don't know if it's going to work. I don't think it is. Okay. So a little glitch here, but I just kind of wondered if you all have been, if you, in your care, elevated white blood cell counts have factored in to what your doctor has recommended. And I will say that white blood cells have been a focus in polycythemia vera very recently. And so white blood cells, we have several different types circulating around, the most common of which are these things called neutrophils. And mostly white blood cells work to fight off bacteria and viruses, but they're also important in things like wound healing. And they make up about only 1% of the total cells in circulation. So whereas the red blood cells, right, are about half of the total volume, the white blood cells are only about 1%. And so the normal white blood cell count is less than 10 times 10 to the 9th per liter, or less than 10,000 per microliter. Again, depending on whether you're American or British units, they're equivalent. So in the same prospective REVEAL study of 2,500 individuals with PV, they also looked at white blood cell count. So whether it was slightly elevated, so was it greater than 11 versus less than 11, And this was in patients with hematocrit that was controlled to less than 45%. And what is striking here to me is that the white blood cell count actually had a greater impact on the risk of blood clots than did hematocrit, which kind of flies in the paradigm of therapy for polycythemia vera, where we've been very hematocrit central. And you'll see this is even a very minor elevation in white blood cell count. So we're talking 1 above normal. And so this has really, really caught our attention. Now, the big question, though, is does reducing white blood cell count reduce the blood clot risk? So we know that increased white blood cells increase the risk, but does lowering them reduce the risk? And I will say that hasn't been specifically studied yet, and probably won't be unless we have some fancy data that we can manipulate, because these studies take so long to complete because the rate of blood clotting events is 5 to 9% per year, and you have to have hundreds of patients in the study. So you're talking hundreds of patients over 5 to 10 years, which becomes a very expensive study. So it's not likely to be done. So I think the best we're going to be able to do is extrapolate. So in terms of extrapolation, there was a study from Professor Claire Harrison in the UK called MAGIC PV, which was a study of ruxolitinib, which is that JAK inhibitor, versus what they considered best available therapy, or BAT, in PV patients who were resistant to hydroxyurea. So they weren't able to keep their hematocrit nicely controlled with hydroxyurea. And in those patients, there was a 44% reduction in blood clotting events with ruxolitinib as compared to best available therapy. And so what was interesting in that is those treated with ruxolitinib actually had better cell count control. So more patients had normal white blood cells, normal red blood cells, and normal platelets with ruxolitinib. So perhaps that's arguing indirectly that the white blood cell count really is important. And if you target it, you can further reduce your blood clotting risk. And then finally, the last but not least cell are platelets. So what are platelets? Well, platelets are these tiny little cells. They don't have a nucleus, they have no brain, they just circulate around, and their biggest thing is they carry around materials that help the blood clot. So I usually call them bricks. So if you were to cut your blood vessel and you wanted to repair that, you could repair it with bricks and mortar. So platelets are like the bricks that come in and lay down, and fibrin is like the mortar glue that glues the bricks together to make that a nice secure clot. There are lots of platelets in circulation, but because they're so small, they make up less than 1% of the total blood volume. And you've probably all heard of platelets because aspirin targets platelets, and platelets have been very well implicated in cardiovascular disease like stroke and heart attack. So it's natural to think that the elevated platelets in polycythemia vera also contribute to things like strokes and heart attack that are seen in PV. What we know in PV about platelets is that they can release their contents a little bit too well. And that's in the very small blood vessels in the body, like in the hands, like in the eyes, like in the brain. And they can cause the blood vessels to constrict down. It's called vasospasm. And those can lead to symptoms like migraine headaches, like numbness and tingling or changing colors in the hands, called erythromelalgia. And sometimes even they can clog up the little arteries around the heart. That can lead to chest pain, but chest pain that's not necessarily from a blood clot. So what do we know about platelet count and blood clot risk in polycythemia vera? Well, it turns out there's surprisingly little published on this. So this data is predominantly from essential thrombocythemia, or ET literature, where the platelet counts are really high. And what's interesting is that in all of these large studies of hundreds of patients, the first one, platelet counts were not predictive of thrombosis. The next one, they saw platelets at diagnosis didn't matter, but on follow-up did. And then the last one, actually not associated with thrombosis at all, but associated with increased risk of bleeding. So the higher your platelet count, the more exhausted those platelets can get, and those bricks become not so great. And instead of forming a nice brick and mortar structure, it's kind of like having sandstone, which is a material that doesn't hold up very well. And so those clots dissolve away and are not very effective. We do recently, from the same REVEAL study, have an analysis of platelets and polycythemia vera. And here they found that platelets, so this is above normal versus below normal, or in the normal range, I'm sorry, was associated with blood clot risk. And this was around the time of the blood clot. So if your platelets were a little bit elevated around the time of your blood clot, that was a risk. But when they looked at platelet count over the course of an entire year, the platelet count actually did not impact the risk of blood clots. So this platelet count could be up because there was stress or something else going on that your body reacted to. But so far, there's really not been any strong evidence suggesting that normalization of platelets would improve the risk of blood clots. So it's not really included in most of our endpoint criteria. So are these moving targets depending on which treatment we use? So I would say for all of our treatments, we definitely want to keep the hematocrit at less than 45%, with consideration of less than 42% for women. The white blood cells, so should we keep them at normal levels? Well, phlebotomy, we're definitely not going to get there. Hydroxyurea, it wasn't studied that way originally, although we all know that hydroxyurea can have an impact on the white blood cells and the platelets. Interferon alpha, however, when I have a patient on that and I'm looking at cell count targets, I generally am targeting normal cell counts across the board. So the way that was studied was they looked at complete hematologic response. So I treat patients in the same way. So I'm also looking for complete hematologic response, which means normalization of all the cell counts. And then the ruxolitinib, I have question marks here because in the original study, it was really hematocrit response, and the secondary endpoints were normalization of white blood cells and platelets. With the data from MAGIC PV, though, I think we should arguably be targeting normal cell counts across the board with ruxolitinib. Okay, and then I promise not to launch too much into research speak, but I really think that when we're talking about management of polycythemia vera, we focus predominantly on cell counts. So we've talked about quantity, but we haven't talked about the quality of those cells. So remember that this is a stem cell disorder where all of the cells made from that stem cell carry a JAK2 mutation, and that mutation turns the cell on. So it turns the cell on to grow, but it also turns on other things. And those other things can actually make the cells very sticky. And one of the things that I study are the white blood cells in polycythemia vera and its cousins, because it's been shown that they are in fact more sticky. So the neutrophils, which normally help to fight off bacterial infections, one of the ways they fight off bacteria is they release their contents into the bloodstream, and it forms this very sticky spiderweb substance that we call nets. And it turns out nets, if you imagine forming essentially a spider web across your blood vessel, catch cells there, and you can get blood clots because of that. So we know that these cells are more activated, they're more likely to stick to blood vessels, and they're more likely to produce these nets. We also know through collaboration with Dr. Joe Perkal at the University of Utah that these neutrophils have higher signals for blood clotting genes. So genes that are generally associated with increased blood clot risk and this increased of hypoxia inducible factor, which is another risk for blood clots. And then work from our group has also shown that the neutrophils actually on their surface, the yellow stuff here, is a very sticky substance called tissue factor, which is essentially the super glue of your blood clotting system. So tissue factor is one of the blood clotting factors and should not be on neutrophils. So it's normally hidden away inside the blood vessel, and only when your blood vessel is cut do you see tissue factor exposed to the bloodstream. Here, it's actually, as you see, circulating around on the neutrophils. So you can imagine that if a neutrophil gets recruited to a site of infection and sticks on the blood vessel, that you might actually get a clot form because there's tissue factor on the surface. And behind here, you can see these are neutrophils from a healthy donor, and you see no tissue factor on their surface, which is the normal situation. So we speculate that it's really not just about number in polycythemia vera and blood clot risk, but it's actually about the quality of these cells. And our hope is that the future of treatment doesn't just aim to normalize counts, but actually aim to reduce the number of abnormal cells and reduce the stickiness of these cells to really improve outcomes. So in conclusion, hematocrit control is imperative in PV with all of our treatments. White blood cell count, a slight increase is linked to an increased risk of blood clots. And while there's no study specifically evaluating the effect of reducing white blood cells, I think it's very reasonable to attempt white blood cell count normalization if the treatment isn't toxic to you. And platelet counts in general aren't linked with the risk of blood clots in polycythemia vera. In fact, really low and really high are linked to bleeding. And there's really no solid evidence that we should normalize the platelet counts. And then kind of food for thought and coming in the future is, I think it's really more about blood cell quality than it is quantity that we'll be focusing on later. And with that, I will end and see, it looks like we have a bunch of questions.
Yes, we do.
Q&A
And
already.
I will pose those questions to you. First of all, thank you, thank you, thank you. This was fantastic. And I've been in the space for a long, long time, over 20 years, and I learned something new every day. And this was so enlightening. I so appreciate this very, very much. It was so significant to all the patients that are watching here. We have tons of questions, so I'll get to those. I'm wondering if an analysis was done with elevated white blood cells as to whether they also had CLL, MBL, CLL, MIPL, and no, not MIPL, MBL, in addition to their PV.
Yeah, so this is a very interesting question. So I mentioned that this is a myeloid neoplasm. So you're not supposed to have a JAK2 mutation in the lymphoid cells. That would be the CLL cells or the monoclonal B-cell lymphocytosis cells, or MBCL. However, it has been found that roughly 10 to 15% of MPN patients have a co-occurring lymphoid malignancy. So that can be CLL, it could be lymphoma, it can be myeloma or MGUS. We don't know why that happens. It doesn't have a JAK2 mutation, but absolutely that does happen.
Okay, sorry about that. I disappeared for a moment. That's good to know. My brother has CLL. What is the significance of elevated monocytes in PV?
Another great question.
Yeah, there's some great ones here.
So, you know, it's interesting. So as monocytes increase, it becomes obvious that that is a marker for higher risk disease. And monocytes are cells that typically like to live in tissues. So sometimes, for instance, in the CMML, a cousin disease, monocytes in the kidney can really lead to kidney damage. We don't know exactly what they're doing in polycythemia vera. What I did not tell you here is that monocytes are actually the classic cell that carries tissue factor. So they can be induced to express tissue factor, and they express a lot more tissue factor than do neutrophils, and they're big, bulky cells. And so while there hasn't been a specific analysis, elevated monocytes are probably bad in lots of ways. But again, nobody has looked at this in terms of targeting and normalizing the monocyte count. So we look at it in terms of bad outcomes, and we might think about changing therapies or doing a repeat bone marrow test, but we haven't looked at it in terms of treatment and outcomes. But that's a great, great question.
It is. And there's so much more to know. I mean, as the years go by, it's just amazing to me. Are PV patients considered immunocompromised, and have you heard of any reason to not take probiotics when you have PV and taking aspirin and Hydrea?
Oh, another great question.
They're
Okay.
all great. Wait till you hear these.
So, immunocompromised is an interesting term, and it's really come to the forefront with COVID. So we've learned a lot from COVID vaccines and from COVID infections. And so what I can say is most patients with polycythemia vera don't have a real immunocompromised state. So if you looked at vaccine response, the vaccine responses to COVID, for instance, were essentially on par with the US population. And hydroxyurea treatment did not seem to affect that. Now, ruxolitinib therapy did. So ruxolitinib does seem to impact the immune system. And so it does make your immune system go down a bit, so you might not respond as well to vaccines. And things like myelofibrosis had a pretty big split. So I think it was like 20 to 30% of the patients with myelofibrosis had a lower than anticipated response to COVID vaccines. Mm-hmm. So there does seem to be some immunocompromise as you go on with disease, but at least at baseline, PV isn't super immunocompromised. Now, a dirty secret here at UNC, because it's very difficult to carve out one blood cancer from another in terms of policies for the hospital, we've left MPN as considered to be immunocompromised. So you may hear two different things because one is actually like what's really happening and one is based on policy. Does that make sense?
Wow, that's something. That is something. You know, you mentioned the possibility of migraines and so on. We actually did a migraine study here. We sent a survey out because we hear it all the time. And especially, and we thought this might be the case, but it was especially from women with PV and ET particularly. And, but I can't tell you how many times, you know, it's so sad because everybody's learning and there's so much work going on and so much, you know, everybody's researching, but there are so many schools of thought on this, and many say, oh no, the migraine has nothing to do with your disease. And I strongly don't believe that, but
I 100% agree with you. And I will say my general approach to migraines, or I try the twice daily aspirin, the low dose aspirin.
yeah.
So if you can otherwise tolerate, I do twice daily. And I just had a young woman in clinic who was having headaches, so migraine headaches that were keeping her out of work at least 3 times a month. And I hadn't seen her for 6 months, but I'd asked her to try aspirin twice a day. And she came in and she said, I've only had 3 migraines in 6 months.
Oh, that's great.
And
that is great.
I think it so clarifies the physiology, right? So it's really platelet driven, and we really need to be targeting that. And we hear this all the time that symptoms were ignored, or they're like, oh no, that's not part of your disease. And then you get to see an MPN specialist and you see the MPN symptom form and you're like, oh my gosh.
Yeah, it is on there. But even MPN docs that we, you know, have on these webinars very often will say, no, I don't think so. And I'm shocked because, and then they can't know everything and they can't, you know, I mean, there's so much that you all are doing. But let me get to some more questions here. Even though there are genetic mutations that are driving the overproduction of inflammatory cytokines, can inflammatory practices like diet, stress reduction, et cetera, be useful?
I love this.
I
feel like this is a setup for Dr. Angela Fleischman's study.
Right.
So, right, this is a hot topic, and it's a hot topic not just in MPN.
Right.
And the question is always, what can I do for myself? And the answer is, unfortunately, I don't have hard data to suggest that there's one best practice here. Now, it's probably, I hate being the kind of classic doctor and saying everything in moderation, but that's sort of where we are. I think Dr. Fleischman, hopefully with her data it's not indomethacin. What is she using? N-acetylcysteine, which is an anti-inflammatory.
Right.
And then the microbiome will hopefully, in Mediterranean diet, will hopefully shed some light on things that we can do to reduce inflammation and really see how that plays a role in PV symptoms and development. We know from the cousin disease, clonal cytopenias of undetermined significance and the clonal hematopoiesis, that an inflammatory environment allows for growth of the stem cell clone that's mutated. And
Mm.
so it absolutely makes sense. I
Yes.
just don't have data on what to do
Yeah.
and how to get there.
And Angela will be speaking in North Carolina with you, that day. And
Absolutely.
she has been working on this, and it's been very interesting. Um, I also wanted to say that we had a PV patient who started taking antibiotics to mitigate the inflammation, basically, and started feeling better. And so I don't know, I can't elaborate, and can't go into detail about that, but it was fascinating to me. If we can't change what's making the cytokines misbehave, is it still worth it to address the inflammation?
So I think it is. And I do think we're starting to get savvy enough, right? So things like ruxolitinib really do target kind of inflammatory production. Interferon, after a short bit, really does target inflammatory production. So I think we are getting some of the cells to better behave. And I do think that targeting inflammation, even if you're not fixing the cells, if you're just targeting inflammation, probably has a positive impact. Again, the biggest issue is I don't know how to target the inflammation right now. So all the studies so far, and it's kind of amazing because if you look at where we all came from, right? So the studies are now being better designed. They're enrolling more people. They are being incredibly thoughtful. But we still don't have, there's just not enough resources, not enough patients to really answer all of these questions. But I think hopefully next 5 to 10 years, we'll have some better results.
Yeah. So we always discuss in our webinars and in-person programs the absolute necessity that if you have an elective surgery or an emergency surgery, that your hematologist is involved in some way. So we have emergency cards that we give to our patients with the hematologist's name, the type of MPN they have, the phone number, everything should be on that card. This person is saying, how should I handle a knee replacement surgery with PV? Any special instructions or precautions?
Yeah, right. Super hot topic. And so my nurse navigator, Jen, is on. And she knows this is a big thing all the time. And I will say we take an individualized approach to these. So if you're super high risk, so if you've had a blood clot before, especially a blood clot in a vein before, then after knee surgery, most of our orthopedic groups are going to recommend aspirin for their anticoagulant. However, I would say aspirin is not good enough in that situation, and you need to be on a blood thinner for 4 to 6 weeks while you're really recovering from that surgery, because that's the highest risk period.
Yeah.
Now, there are other patients, right, who have really very limited risks for blood clots. As long as they're on hydroxyurea, then I feel much better about their blood clot risk. I know that they're going to be up walking around very soon, and their risk of blood clots go down. So I would say aspirin is just fine. Now, with either of these, what's really fascinating is we talk a lot about blood clots, but one of the big things that pops up is the risk of bleeding is way higher in patients with MPN and surgery than patients who don't have MPN and surgery. So I think one of the bigger things to talk to your doc about is, what is my risk of bleeding? Do I have risk factors? Do I need to be tested for something like von Willebrand factor activity? What are my platelets doing? And so hematologists usually are going to talk to you about, what surgeries have you had in the past? What happened? Did you need blood transfusions? Those are all things that we use to make our decisions about what to use in the perioperative period.
Okay. Yes. Okay, so if the aim of PV is to reduce the risk of clots, why isn't Eliquis recommended?
So this is why I'm doing research, in fact. So I think that's a beautiful question. So one of the biggest issues in MPN is that when there is a clot, so a blood clot in a vein, we generally are going to use blood thinners like Eliquis. And so in the general population, that is highly effective at reducing the risk of another blood clot. So in general, the recurrence rate in the general population is going to be well less than 3%. However, when you look at patients with MPN who've had a blood clot, and most of this comes from warfarin data, which is Coumadin, the failure rate is 30%. That is wild. So we have a 10-fold higher failure rate of blood thinners. And so, and there have been lots of studies looking at whether adding aspirin is necessary. And mostly what we've seen is that just increases your risk of bleeding and it doesn't do anything to your risk of clotting. So I really think it's, we have to address the stickiness of the cells, which is not really easily addressed by things like Eliquis and Xarelto and warfarin or Coumadin.
Okay, so we get a lot of questions, and we actually just had a webinar that talked about some of the idiosyncrasies of having a PV diagnosis, for example, flying. And this person asks, should they wear retention socks when they are flying?
Yeah, so flying is a high risk situation for anybody, right? So, and we're specifically talking primarily about transatlantic flights. So flights that are over 6 hours and generally even longer. So even in the general population, the risk of a blood clot goes up when you fly. So you imagine if you have a basally increased risk of blood clots, that probably goes up higher than when you fly. Or when you go, for instance, to Utah. So Dr. Pakal also demonstrated this. So he and Dr. Spivak in Baltimore at sea level, his population in Utah at altitude, there was a significantly increased risk of blood clots in those individuals who lived in Utah than Baltimore. So it's very clear that there's an impact here. But what to do about it is a very good question. So we don't have really data that compression socks work. We know that getting up and moving around. So I usually tell my my patients, you know, at least every 30 minutes, I want you up walking around or pumping your legs, getting that blood moving from your calves back up to your heart. Stay well hydrated because we know dehydration layers on. And if I think that you're higher risk, I can't get your white blood cell count down, or there's something else about you that seems high risk, you have really high cholesterol or you smoke, please don't smoke if you have this disease. But if you do, then maybe I'm going to give you a very short-term blood thinner for your flight to help protect you during that flight. So again, it's not 100% protective, but it's better than nothing. And that is something that we do for many of our patients who travel internationally.
That's a great. How concerning is hydroxyurea taken orally with an effect on the oral mucosa of the mouth? And over the years, I've heard this and seen it, and worked with somebody that actually had mouth sores. It was horrible. What are they doing now? What can be, what can mitigate that issue?
Oh man, I wish there was like easy mitigation here. So we just had this pop up in clinic last week. Somebody been on stable doses of hydroxyurea for years, and then suddenly had terrible mouth sores. And so, there have been studies linking, and not specifically in polycythemia vera, but with hydroxyurea in general, low B12, low iron, which, right, is always an issue in polycythemia vera. So we try to do things to optimize B12 and iron where we can if you're not maintained on phlebotomy. And I think the lowest dose of hydroxyurea possible, it's because we know that the mouth ulcers seem to be dose related. And I think that's one of the reasons I wanted to have the cell count talk, is because what I find from the community is that outside physicians will accept a hematocrit of less than 50, but they'll push the platelets to be normal. And so I will have patients get toxic on hydroxyurea because they're pushing, that 2 grams a day, 2.5 grams a day to get the platelet count normal. And so it really needs to be a focus predominantly on hematocrit, secondarily on white blood cell count, and platelets are like, I don't have great data that getting your platelets normal are helpful. So most of my patients have learned, I've conditioned them to I want to know if your platelet count is really low or really high, but I don't want you to freak out. If your platelet count is 600 and you feel fine, that is completely fine. I don't want you to increase your hydroxyurea to make yourself sick.
That's a great point. Great point. If one is on cytoreductive therapy and your hematocrit jumps up, at what level should you have a phlebotomy, or should you just check again later? And this is an interesting question to me, because very often I'll hear a physician say, it could change tomorrow, or next week it could be completely different. You may have eaten something, done something, your answer to that question.
So, this happens to us all the time. And I'm surprised Jen hasn't turned her camera on, because we even get a difference between labs. So one of the labs that we use always has a significantly higher hematocrit value than our UNC lab, and it drives us nuts because when they come for phlebotomy, their hematocrit's completely fine. And so it is all over the place. I generally take the approach of trusting but verify. So if you've been well controlled on cytoreductive therapy, you're not having any symptoms, what I'll generally do is recommend that we repeat unless your hematocrit is crazy high. So if you're well above 48%, that's unlikely to go to normal, to less than 45 on just a repeat count. But if you say your target's less than 45 and you're 46, I generally am going to say, let's repeat that. Stay hydrated. Let's repeat it, see where we are, and try and determine whether or not this is a blip or whether it's real. Because we don't love therapeutic phlebotomies when you're on reductive therapy. In fact, we don't, most of us, maybe not most of us. I live in a little bubble. But I don't love therapeutic phlebotomy at all. So what we've learned about therapeutic phlebotomy, when you compare it to hydroxyurea or interferon, right? So you look at the Cornell data, this 28-year, it's retrospective data, but patients did much better if they were on hydroxyurea or especially interferon in terms of myelofibrosis and overall survival. There's been a lot of interest in iron deficiency making things worse, in polycythemia vera. And I certainly am of the camp that long-term iron deficiency, as induced by therapeutic phlebotomy, is not a good thing. And I would do what I can to avoid all the therapeutic phlebotomies.
Good for you. Can you discuss, and this was another side effect or issue that we hear quite often, and that is neuropathy and treatment options. And that's another area that some MPN docs will say, oh, that's not related to your MPN. I firmly believe it is, and I'm not a physician, but because I've heard it so often, and it could not necessarily be the MPN, but there's something going on that is, relative.
It's fascinating. So most of the kind of neuropathic pain that we see is really this erythromelalgia, which is where the platelets, right, are releasing their materials into the small blood vessels, and those are clamping down and causing essentially no blood flow to the area, which can affect the nerves, so it can be painful. It can change the color of your toes and fingers. So most of that is reversible with aspirin. But we do see some patients who have this, what they call small fiber neuropathy. I have no idea how to explain it. It's like it's in the absence of diabetes. So far, like, I don't know if it's ischemic. So is this like legitimate blood clots, not just clamping down of blood vessels? I really don't know. I haven't seen great management for it. I thought it was very interesting when the momelotinib studies right, had that signal for neuropathy that wasn't really well explained. I'm not sure. I wish I had a better answer for you. I think that is a completely open area for evaluation, and it would be super interesting to really get a group of patients who have this small fiber neuropathy together and look at the characteristics for each one of them. There's probably something underlying it.
And we could actually facilitate something like that. So perhaps you would be interested in helping us with that. We could bring the patients together, get that cohort of patients, and then at least in this kind of setting, in a webinar setting, just to ask questions. One more question, and then I want to hear what your thoughts are of the future in MPNs. If you are unable to take BESREMi at higher doses due to liver enzymes as prescribed, is there a difference in outcomes in reducing JAK2 between pegasys and BESREMi?
Oh, that's also an interesting question. So I'm not aware of a head-to-head comparison of the two and the reduction in JAK2 allele burden. So in fact, my understanding is based on the original pegylated interferon data, it looks very similar to ropeg interferon. It just was studied a little bit differently, right? So it was like built in the study for ropeg interferon, and it wasn't necessarily always built in as a first-line endpoint in the pegylated interferon studies. We generally have better luck with ropeg interferon in terms of less liver toxicity and less symptoms, but we do have patients who kind of go both ways. I would say don't get frustrated. Interferon is kind of a long-term, I call it the tortoise and not the hare. So when you look at the JAK2 allele burden reductions, right, the biggest gains that they saw in most of the studies was at 2 years, and those deepened over the course of 5 years. So this, we'll see if the dose, so if ramping up the dose of ropeg interferon more quickly actually impacts the JAK2 allele burden reduction. I'm not sure yet. Or does that even matter? Or is it really kind of the low and slow? My gut tells me it's slow and slow, but I'd like to see data.
Yeah, and that's been a question out there for 21 years since I've been around, and that is, does the allele burden affect how a person feels? And and some say yes and some say no, and most say there just isn't enough evidence out there to to say that that's what's happening. So in closing, first of all, thank you so very, very much. We'd like to also invite you, I know I'll see you in August, but I'd also like to invite you to our 10th annual Women in MPN program in New York City on September 27th. You'll be joined by many of your other colleagues, and it would be wonderful to have you with us. I'll send you a formal invitation for that. And in closing, I always ask our MPN specialists to share or impart some wisdom about the future. What do you see happening in the future in MPNs? Anything exciting that's going on in your lab, and just some good news to leave with.
Sure. Thank you so much for having me. And thank you, all the patients, for showing up. I will say that I think the thing I'm most excited about in MPN is that since 2005, when JAK2 was discovered, there has been so much explosion of understanding. And I think we're finally getting to the point where we're not going to be treating patients like Dr. Damashek did in 1950. That is so exciting to finally be making this progress. Again, I think we're going to not just focus on the number of cells in polycythemia vera and ET. We're going to focus on how do we get rid of those abnormal stem cells, and how do we prevent the things that are not just theoretically possible, that are really important to patients, like progression. And that is so exciting, because we've made essentially zero progress treatment-wise.
Sure.
Up until very recently.
Yeah.
And I think what's super exciting is the endpoints for studies are going to change to reflect what we understand about the disease and what's important to patients. And that is so exciting.
Absolutely.
I
Yeah.
hope that we find a biomarker that reflects this, right? So other blood cancers have found blood markers or tissue markers that you can use that are a surrogate endpoint for these long-term clinical studies. If we find that, it's kind of the holy grail in MPN. If we can find that, then we can actually fund studies that don't have to go on for 10 years that could make big impacts to patients. And so excited about that. And then one thing I want to tell you all about is Dr. Stefan Koschmieder and I are starting to work on understanding why chronic kidney disease is happening in MPN. So I was a bit embarrassed. Up until a few years ago, I did not realize that 80% of MPN patients were affected by some degree of chronic kidney disease.
I
That's a
did not
wild
know
number.
until today, after
Yes,
21 years in this space. I've never heard this.
that's a
Both
wild number.
Mallory and I looked at each other and said, we've never heard this.
So you have to go look at his publication. It is absolutely wild, and it's been corroborated by a couple of groups. And so we actually have a mouse model of polycythemia vera with a JAK2 mutation. And in our mouse, we can confirm that the kidney function is reduced as compared to the healthy control mice.
Unbelievable.
And so we're starting to look at why that might be and to see if we can, how do we reverse this? And can that be used as a marker of treatment response in MPN? And so watch out for these things. We might be
Yes,
calling on everyone
yes.
to donate urine and blood samples for our studies.
This is very interesting and so timely. And, you know, we're forming an MPN International Working Group, which I would love for you to be a part of also. And the reason why what you just said is so important, because we are looking at endpoints and secondary endpoints, and the impact that these new drugs and this research is having in those areas that the FDA needs to be aware of and needs to understand how important they are. You know, yes, the spleen size is so very important, absolutely, no question about it. But there are also these other endpoints that need that warrant looking at and paying attention to. So with
Absolutely.
that, I'm sorry if we did not get to your questions, those here with us today. We always try to answer as many questions as possible. Dr. Reeves, we thank you so very, very much for being with us today, and I will be in touch real soon. And have a wonderful day, everyone, and we'll see you soon.
Thank you.
Bye.